Okay, I think 12:03, let's get started. Everyone, thank you so much for joining our Grand Round session today. And I'm very excited to introduce two of our second year fellows who are here to present very interesting cases today. And we'll have enough time after each of their sessions for questions. We'll start with Dr. Khanam first. She's a second year fellow who completed her medical school and internal medicine residency at UPMC McKeesport Hospital in Pittsburgh, Pennsylvania. She worked as a hospitalist for a few years before joining our fellowship program at MUSC. She's been interested in hem-onc since her medical school and has been interested in continuing. I think she's thinking about academic medicine and especially maybe GU. So she's still deciding on what she's going to go to next, but we are very excited that Dr. Khanam is going to present our first case. And then we'll hear from Dr. O'Brien, who's also our second year hematology oncology fellow. He earned his medical degree from Virginia Commonwealth University, where he graduated in the first quartile and received multiple scholarships and awards. He then did his internal medicine residency at MedStar, Georgetown University Hospital. Dr. O'Brien has a strong background in clinical and translational research with particular interest in biliary tract cancers and intrahepatic cholangiocarcinoma. He also has conducted research at the Lombardi Comprehensive Cancer Center prior to joining us. And he's also interested in addressing issues with disparities in cancer care. So again, we are excited to have Dr. Khanam and Dr. O'Brien here. We'll hear from Dr. Khanam first, and then Dr. O'Brien will join. Thank you.
Thank you so much, Dr. Siva. Good afternoon, everyone. I am going to start my presentation. Let me share my screen. Okay, and I just wanted to confirm everyone can see my screen, right?
We can see it.
Okay, sounds good. Thank you. All right. And then it's moving, right? I know there has been some issues with the presenter mode. Is it working?
Yeah, it looks good to me, Roswana.
Okay, sounds good. All right. Okay, everyone, welcome to Grand Rounds. As Dr. Siva mentioned, I'm a second year hematology oncology fellow. I'm going to be the first presenter, and James will present after that. So I'll try to finish it in half an hour, so I give James enough time. I'm going to talk about enfortumab vedotin and pembrolizumab in untreated advanced urothelial cancer, pretty groundbreaking in GU oncology, which resulted in first-line treatment of this regimen in urothelial cancer in locally advanced or metastatic setting, and I'm going to discuss it today. I'll start with a case first, and we will talk about the paper and how it got the approval to be used. So my patient is a 71-year-old. Let me try to see. I can. I'm not able to minimize it. Okay. All right. So 71-year-old male. He developed gross hematuria for some unknown period of time, mostly in summer 2023. He was being followed up with urology. He initially underwent cystoscopy and transurethral resection of bladder tumor. We call it TURBT. And he was found to have a non-muscle invasive urothelial carcinoma of bladder. And then he was treated with a course of induction BCG. He had the recurrence of disease afterwards with the recurrence of symptoms. So he received intravesical gemcitabine docetaxel. Then he got a novel preparation of intravesical gemcitabine as part of Sunrise trial. He got the he had a re-TURBT or bladder tumor resection, which showed that he still has non-muscle invasive bladder cancer, but it was high grade. High grade is the reason why urology ordered a PET CT, and patient was found to have left common iliac and left periaortic lymph node involvement. Left common iliac is a regional lymph node that made it an N3 disease, but left periaortic lymph node is a nodal metastasis, which made the disease to be a stage 4 disease, even though it is non-muscle invasive. So patient was his care was transferred to medical oncology, and after seeing the patient, we started him on enfortumab vedotin and pembrolizumab based on the phase 3 EV302 study, which I'm going to discuss right now. So this is a pretty groundbreaking study, enfortumab vedotin and pembrolizumab in untreated advanced urothelial cancer. It got published in March 2024, but the regimen already got accelerated FDA approval the prior year in April in cisplatin ineligible patient, and then got traditional approval in December 2023 before the paper finally got published. Because of this phase 1b/2 study where it showed that it has an excellent response in the patient population. So the method, it is a phase 3 global open label randomized trial. 185 centers from 25 countries participated in this trial. North American countries, Europe, Asia, they were all involved. 2 arms. Arm A was the treatment arm, EV Pembro, and then Arm B was gemcitabine associated along with cisplatin or carboplatin, depending on eligibility for cisplatin. And patient, of course, had untreated locally advanced or metastatic urothelial carcinoma. Now, I just wanted to briefly talk about this mechanism of action, and I'm not going to go into too much details, but pembrolizumab, we all know it's an immune therapy against PD-1. Enfortumab vedotin is an antibody drug conjugate where it comprised of anti-nectin-4 IgG1 kappa monoclonal antibody, which is conjugated to monomethyl auristatin E, MMAE. That's a chemo payload with a linker. Now, nectin-4 is usually expressed in skin, sweat gland, salivary gland, urothelium, in lungs, pancreas, ovaries, and it is overexpressed in urothelial carcinoma. And that was the reason to get this medication designed against the anti-nectin-4 or nectin-4 receptor. And then later on, of course, the chemo payload is inserted into the cell, causing tumor lysis. The inclusion criteria for this trial, definitely patients have to have the definite confirmation of urothelial cancer. The disease should be measured as per RECIST criteria. Patients should not be receiving any prior systemic treatment, such as like any immunotherapy, PD-1, PD-L1, CTLA-4, or any MMAE chemo load containing antibody drug conjugate. However, some patients who have received neoadjuvant or adjuvant chemotherapy with cystectomy and they had disease recurrence 12 months after the completion of systemic treatment, they were still eligible. And of course, there has to be cisplatin and carboplatin eligibility, age more than 18. The ECOG performance status should be less than 2, and if it's more than 2, or if it's 2, then hemoglobin should be more than or equal 10, GFR more than or equal 50, and patient cannot have class 3 heart failure. Here, the exclusion criteria, as I mentioned, any previous systemic treatment with immunotherapy or MMAE-based antibody drug conjugate, they were excluded. Patients who were not eligible for cisplatin or carboplatin were excluded. Uncontrolled diabetes or any limiting organ dysfunction, such as pulmonary fibrosis, pneumonitis, MI, CVA, they were excluded. Anyone having life expectancy less than 3 months were excluded. CNS metastasis, leptomeningeal disease, definitely they have life expectancy less than 3 months. So those patients were also excluded. Any secondary malignancy patients are dealing with in past 3 years, or they have residual disease, then they were also excluded. Any kind of active infection, active hepatitis C infection, tuberculosis, or even the patient who had prior hepatitis B or HIV infection, they were also excluded in this trial. Now, let's look at the randomization of patients. Now, 442 patients, like total sample was 866. 422 patients were in the EV Pembro arm and 444 in the chemo arm. 420 patients received EV Pembro. There were 2 patients who did not receive it because of some incorrect randomization. And 11 patients in the chemo arm did not get chemo. Either they were randomized incorrectly, or they were found to have much advanced disease that they were thought of, or there were some physician or patients maybe decision making, which resulted in like maybe not 444 but 433 patients in the chemotherapy arm. Now in the EV Pembro arm, you can see 144 patients still remain on the study and 153 had the progression of disease. In the chemotherapy arm, there were 0 remaining patient in the chemo arm and 73 had progressive disease. Let's look at the baseline characteristics baseline. I'm just gonna zoom in here. I'm not sure whether you can see the same way I'm zooming it in, but I wanted to emphasize on certain criteria in this patient population. So it is a disease of elderly. You can see the median age is like 69 in this patient population. Male predominant disease, so almost 78% patients were male and 20% patient female. In case of race and ethnicity, you can look that most patients were, again, it's a Caucasian predominant disease. So most patients were like Caucasian, almost 70%, Asian were like 20%, and Black was pretty underrepresented, maybe around 1%. Now, of course, we have North America, Europe, and rest of the world. There are like some Asian countries were involved. Also note that these patients, because they are elderly, their creatinine clearance, like almost 43% patient had like creatinine clearance less than 60 ml per minute, and they were cisplatin ineligible as well. They did randomize patients depending on PD-L1 status and the Nectin-4 expression as well. We have some subgroup analysis on the PD-L1 expression, be it high or low, but not on the Nectin-4, but it's still randomized patient. The primary site of disease is mostly in the lower tract. 70% of the patient had lower tract disease and 30% patient had upper tract, like renal, pelvis, or ureter. And lower tract, I mean urinary bladder and urethra. So efficacy, the median duration of follow-up was 1.5 years in this trial. And the risk of progression of disease was 55% lower in the treatment arm, and risk of death was 53% lower in treatment arm. So pretty significant. You can see progression-free survival and overall survival almost doubled in the EV Pembro arm, 12.5 months versus 6.3 months in chemo arm, and overall survival 31.5 months in the treatment arm versus I think it was 16 months in the chemo arm. And patients alive at 12 months was 78%. And we can see that in the chemo arm where almost like 60% patients were alive. Now I'm looking at the progression-free survival in this patient. As I mentioned, almost double response we saw. Like at 12 months, 50% patient had like progression-free survival and 21% in the chemo arm. And in the EV Pembro arm, 44% patient had progression-free survival at 18 months and 11% patients in the chemo arm. So almost, I would say, doubled in the EV Pembro arm. And here, the progression-free survival, depending on whether patients are cisplatin eligible, ineligible, PD-L1 high or PD-L1 low, and we can see similar responses in the EV Pembro arm, regardless of all these criteria. So that's progression-free survival was one of the primary endpoints. And then again, this is a forest plot, and we can see in each subgroups, it favors EV Pembro than the chemotherapy arm. Let's go to overall survival, which was another secondary endpoint. Again, 78% patients were alive at 12 months in EV Pembro versus 61% in chemo arm, and almost 70% patient in EV Pembro arm at 18 months and 45% patients in the chemo arm. So pretty significant overall survival. And they have subgrouped them again on cisplatin eligible, ineligible, PD-L1 status high, PD-L1 status low, and we are seeing similar overall survival in all these subgroups. That's again forest plot showing the overall survival. Again, you can see in every subgroup, it's favoring EV Pembro rather than the chemotherapy arm. Now, it's important to note that in North American population, it is crossing the confidence interval. At that time, avelumab, which is another immunotherapy, was approved for urothelial cancer, and almost 30% patients were receiving avelumab in the chemotherapy arm after completion of 6 cycles of chemotherapy. So that might be reason why it is crossing the confidence interval, but you can see, and again, also the sample size is much lower in the North American population rather than in Europe or in the rest of the world. And you can see that it is not crossing confidence interval in Europe and rest of the world. So which tells us that avelumab might be the confounding factor here. Okay, and then again, efficacy, this is secondary endpoint. So primary endpoint was progression-free survival and overall survival, and secondary endpoint were these efficacy depending on the RECIST criteria, version 1.1, pain progression, or safety profile were the secondary endpoint. And we can see that in every variables, be it complete response, partial response, EV Pembro is showing much higher numbers rather than the chemotherapy arm, like 127 patients had complete response, and more like 50% reduction from the measurable disease prior to the treatment regimen initiated. So that's complete response, and 127 patients had complete response, where 55 patients from chemotherapy arm had complete response. So overall response rate was 67.7% in EV Pembro and 44.4% in chemotherapy arm. Median time to response was similar in both the arms, but median duration of response was not reached in EV Pembro arm and 7 months in chemotherapy arm. Again, this is another secondary endpoint. You can see the treatment-related adverse events, which causes dose reduction in EV Pembro, almost 41% patients in treatment arm and 38% patients in the control arm. There were 35% discontinuation of treatment in the treatment arm and 18% discontinuation in the control arm or the chemo arm. 4 patients died in the treatment arm and 4 patients again died in the chemo arm, multi-organ failure or the toxicity from the associated regimen they have been receiving for the cancer. Again, we can look at the safety profile here. So in the treatment arm, most patients were having neuropathy, almost like 50% patient in the treatment arm. Skin toxicity, again, enfortumab vedotin and pembrolizumab both can cause this. So almost 40% patient had pruritus, maculopapular rash. And in case of grade 3 toxicity, rash was seen in 77.7% patients. Hyperglycemia, which is, of course, can happen from both the regimen in 5% patients, and then almost 5% patient in neutropenia. Now, in case of EV, I think with thrombocytopenia, some ocular toxicity or neuropathy, if it was grade 2, then there were some, they still continued the enfortumab vedotin. However, if there was grade 3 or above complications, then that was the only time they held EV until it became grade 1 or less, and then they started. For pembrolizumab, for grade 2, they held pembrolizumab and treated with systemic steroid and then resumed it if it got down to grade 1 or less. But any grade 3, grade 4 toxicity, they just stopped pembrolizumab. And in chemotherapy arm, we can see 36% patient had fatigue, which is we all know with the chemotherapy happens, and nausea. 39% patient, 56% patient had anemia, and neutropenia in 41.6% patients. That's a safety profile. Time to pain progression was another secondary endpoint, and here we can see that it took 14.2 months for the pain to progress in treatment arm in comparison to 10 months in the chemotherapy arm. Subsequent therapy now, as we have seen, 144 patients were in the EV Pembro arm and no patients were in the chemo arm. And patient on the chemotherapy arm in North America, 30% patients were getting maintenance avelumab at that time. So that is another immunotherapy which was also contributing to patients' response as well, which we saw that in overall survival was crossing the confidence interval. And patients in the EV Pembro arm, most of them got some platinum-based therapy when they had progression of disease. So I would like to try to make the point that EV Pembro had better overall survival, progression-free survival in all population. And they even had a pan-Asian subgroup analysis where we found a similar result. So that resulted in FDA approval of this regimen for locally advanced or metastatic bladder cancer. The limitation of this study is Black patients were definitely underrepresented, and then most histology was urothelial cancer in this study. But there are other types which are like squamous, glandular, epithelial subtypes, which was not presented well in this trial again, which is also very difficult to treat regardless. So those patient population were not well represented in this study. Now, the study has an updated result. Now, after 2.5 years, it looks like that the progression-free survival is still the same, 12.5 months versus 6.3 months, but overall survival has improved, 33.8 months in treatment arm and 15.9 months in the chemotherapy arm. Safety profile is the same. Now, November 2025, FDA approved perioperative treatment of either the immunotherapy pembrolizumab or EV Pembro combination along with cystectomy in cisplatin ineligible patients who otherwise could have gotten radical cystectomy with pelvic lymph node dissection. And we found out that in the EV Pembro arm, the event-free survival, which was like either progression of disease or relapse or death, was not reached versus 15.7 months in the radical cystectomy and pelvic lymph node dissection. And again, median overall survival was not reached, and 41.7 months in radical cystectomy and pelvic lymph node dissection arm, so which caused its approval in the perioperative setting as well. So back to our case, our patient was started on EV 1 milligram per kg, but we then had to reduce it to 0.75 milligram per kg because of neuropathy. And then we had to stop pembrolizumab on this patient because of nephritis after 5 cycles, which did not improve with steroids. So we had to stop pembrolizumab after 5 cycles, but he was able to get EV 8 cycles. He did have an excellent response to this EV Pembro, but because of the toxicity profile with neuropathy and nephritis, we had to switch him to a different agent, ardafitinib. That's another FGFR3 mutation targetable agent, and he had that mutation, so we started him on that treatment, and so far he's doing fine. It's been 2 years already, since his diagnosis, which is great. So here I'm going to end my presentation. If anyone has any question, I'll be happy to address that, and then James will take over.
Thank you for presenting, and thanks for not having a Malheme case. Almost all the other cases are always Malheme, so I for sure appreciate that.
You're welcome.
No questions?
It's a great presentation, Rizwana. It's a really good trial, a good regimen. Very little to criticize on the study there. I think you pointed out the only thing that it has gotten some minor critique for is just the standard of care changed while they were conducting the trial, and maintenance immunotherapy became part of the standard of care, which wasn't mandated in the trial, but a minority of patients got. Any patients you would not give this to for first-line metastatic disease?
I think the exclusion criteria, I would look into that because I think there was one patient in phase 1B or 2 where the patient really died from diabetic ketoacidosis from EV. So if the diabetes is uncontrolled, then definitely I don't think I would do EV Pembro in that patient, because I saw that the patient just passed away from DK, which is very unfortunate. And also, of course, if they're having any other autoimmune side effects or I think we can still try on leptomeningeal disease because the immunotherapy has some CNS penetration, which they excluded in the study. I think that they did because of the overall survival, but I think we can still try. But I think those limiting toxicities, which can further worsen in patients like diabetes, uncontrolled diabetes, or bad neuropathy, or then I might be a little hesitant on starting this regimen.
Yeah. I'd say the neuropathy is probably the most common thing that might give pause. That and performance status. It is a pretty toxic regimen. I think you can probably give it to more people than you can give a gem-cis to, but it's not easy to get patients through. But that efficacy difference is of a magnitude we don't see all that often. Like, it reminds me of when they were first comparing EGFR TKIs to chemotherapy in lung cancer. Like, that huge gap in survival and response and performance and PFS is pretty impressive. Great talk.
Thank you, Dr. Becker.
Thank you, Razvana. Now we'll hear from Dr. O'Brien.
All right, sounds good. Thanks, Razvana, and thanks for the introduction earlier. Dr. Siva, let me see if I can pull my presentation up here. Righty. Can you guys see and hear me okay and see my slides?
Yep.
Yes, we can. Thank you.
Okay. So I'm going to talk about a case that I saw last year as a first-year fellow. I'm going to focus mainly on the case itself and kind of the patient's hospital course because I found it particularly interesting. This patient got really critically ill, but ended up having really a pretty astounding good outcome with some HER2-directed therapies that we treated her with. But I'll also try to tie in some of the kind of landmark clinical trials that support different HER2 agents in the treatment of metastatic HER2 breast cancer. So to start us off here, the patient was really an otherwise healthy 40-year-old female without much significant past medical history, who initially presented to our system back in November of last year for evaluation of blurry vision. The patient actually lives in the Savannah, Georgia area, and saw an ophthalmologist in the Hilton Head area around the time of October 2024. At that time, she actually endorsed symptoms beginning in June, was having some kind of mild floaters at that time. But over the course of the next few months, her symptoms progressed, became associated with blurry vision. So she saw her local ophthalmologist who performed a retinal exam, and they actually visualized left retinal detachment on their exam. And then they subsequently referred her to Storm Eye here at MUSC for further evaluation. So she ends up seeing us on November 8th. Our ophthalmologists repeat a retinal exam, and I included some screen grabs, which were actually in the patient's chart from the media tab from that visit. So if you look at the left image, that's a picture of her retinal exam of the right eye, and you can see that she has these multiple kind of multifocal what they described as creamy white choroidal lesions with scattered intraretinal heme. And then there wasn't an image in her chart of the left eye, but I did find this ultrasound screen grab from a later date, which kind of shows the pertinent findings. So I'm not an ophthalmologist, but I did my best to kind of label the pertinent anatomic structures, and this kind of hyperechoic, flat structure floating in the middle here, I believe is her detached retina. So based off of their evaluation, ophthalmology was actually pretty immediately concerned for choroidal metastases from a cancer of unknown primary. And they actually recommend some additional workup with cross-sectional imaging with MRIs of the orbits and brain. So I've included some images of the pertinent findings there. So if you look at the leftmost image, this is the MRI of her orbits. It's a pretty subtle finding, but if you look at the left globe, kind of along the dorsal aspect, kind of at the retina, you can see this really subtle kind of indentation, which is abnormal and shouldn't be there. And then if you look at the image on the right, this is from her MRI brain with and without contrast. It basically shows further characterization, and it actually shows a mass sitting right behind her left retina, which is obviously abnormal, and it actually enhances with contrast on MRI. which kind of furthered our concern for metastatic disease involving the left lobe. I didn't include these images, but also noted on her MRI brain were additional enhancing lesions within the brain, and then also some soft tissue lesions within the left frontal scalp, which are actually palpable on exam, plus a third lesion within the left parietal skull. And then she also got an MRI T-spine on the same day, which showed, unfortunately, multi-level, likely metastatic disease involving several thoracic vertebrae. So she had these images performed on the 13th here at MUSC, but she was actually feeling so unwell on that day that she decided to present to the emergency department on her own after having those MRIs performed. And she presented there because she was actually having worsening bilateral vision, as well as new kind of progressive shortness of breath and dyspnea. I put kind of her pertinent vitals, exam, and lab findings here. So as you can see, she's hemodynamically stable at this time, but pretty significantly tachycardic. And then she's tachypnic and kind of borderline on her O2 sats on 4 liters of nasal cannula. And again, this is a 40-year-old, otherwise healthy lady without any history of lung disease or smoking history. On exam, the emergency department physicians are able to appreciate these kind of smooth, raised erythematous lesions of the mid-scalp. And then also pertinent, she has a large purulent wound of the right axilla, as well as a wound of the right breast. And per discussion with the patient, she actually noticed these wounds arise about 3 to 4 months prior. She had reportedly had some mechanical trauma to that area when she was at home fixing some shelving. And these wounds really started pretty mild, but had kind of progressed over the subsequent months. And then on her lab work, really not that impressive. She has this kind of mild normocytic anemia, very mild neutrophilic leukocytosis, a mildly elevated AST. Of note, her ALP phos is pretty significantly elevated to 278, likely going along with those sites of osseous metastases seen on her imaging. And thankfully, her bilirubin was normal. So the emergency department physicians, given her acute hypoxia, get additional imaging, which I've included here. So they obtain a CTPE, which thankfully did not show any pulmonary embolism, but does show a large right breast mass, which is shown on the leftmost image, measuring about 4.4 centimeters by 6.6 centimeters. And there was also some appreciable right axillary lymphadenopathy on that scan as well. And then looking at the middle image within her lungs, as you can see, she has these kind of diffuse, multifocal, well-circumscribed nodules, which also appear concerning for metastatic disease, plus, pretty diffuse associated ground glass opacities concerning for a potential superimposed pneumonia. And then the rightmost image shows a scan of her abdomen. And unfortunately, as you can see, it looks like there's also hepatic involvement with several masses within the liver, as well as lesions within the spleen, axial, and appendicular skeleton. So unsurprisingly, she ends up, getting admitted to the hospital. So I'll kind of briefly outline her hospital course. So, given the imaging findings discussed previously, she's diagnosed with this presumptive de novo synchronous metastatic breast cancer, given the breast mass appreciable on exam, as well as the imaging findings showing, a lot of metastatic disease burden at multiple sites. In speaking with the patient, she actually has a really supportive family who is here with her throughout all of her hospitalizations, and her parents in particular are really great historians. Interestingly, the patient's mother was actually diagnosed with breast cancer also at a young age, at the age of 49. And since she's such a great historian, she has some more details. So she knows that her disease was hormone receptor negative, but HER2 positive. And then also of note, the patient's mother's cousin also had breast cancer. That individual reportedly underwent germline genetic testing, which was negative, including mutation testing for BRCA1 and BRCA2. And then also of note, on her dad's side, she had multiple extended relatives with a history of ovarian cancer. So a pretty significant family history, both for breast and ovarian cancer in this patient. So she, like I said, gets admitted to internal medicine. IR gets consulted for a biopsy, which they end up performing on November 14th, and I'll discuss the results of that on the next slide. We are consulted for systemic therapy recommendations. As you guys might imagine, we basically say we'll follow up the results of the biopsy, and then our therapy recommendations will be based on those results. Ophthalmology gets brought on board as well, just given that the patient was having worsening right-sided vision. They repeat a retinal exam, which basically just kind of redemonstrates the findings that I discussed previously. Ultimately, they feel there weren't really any acute interventions that they could perform to preserve her remaining vision, apart from just treating the underlying systemic disease. And they apparently discussed with one of their retinal specialists who considered radiation therapy to the right retina, but they felt that that would increase her risk of radiation retinopathy and cataracts. And my understanding is that is primarily used for primary ophthalmologic cancers like retinoblastoma and choroidal melanoma. So that basically gets deferred. So like I said, she had those 2 biopsies performed during her first hospitalization. And this slide summarizes all of the final pathology from both of those biopsies. So the top 2 text blocks are from the liver and the bottom 2 are from the breast mass. If you look at the top right, so this is the path from her liver lesion core biopsy, which ultimately results as metastatic, poorly differentiated carcinoma. And notably, it stains positive for GATA3, which is a breast marker, which goes along with our presumptive diagnosis. And then if you look at the bottom left, this is part of the pathology from her right breast mass core biopsy, which essentially confirms that diagnosis, showing invasive ductal carcinoma. The receptors are listed below that. So interestingly, this patient was actually ER positive in 85% of tumor nuclei with 3+ by IHC, but she was PR negative, which I feel like is kind of a more rare presentation. Generally, when I see hormone receptor positivity, they're both ER and PR positive. And from what I've read, PR negativity in the context of an ER positive breast cancer suggests kind of impaired estrogen signaling and a more aggressive tumor biology. So that's kind of a negative prognostic sign. And then importantly, in this case, she was strongly HER2 positive, 3+ by IHC. I listed her Ki-67 at the bottom as well, which is pretty high for a breast cancer at 49%, suggesting pretty high proliferative index. And then I put some of the grading information in the bottom right, perhaps unsurprisingly, based off what we discussed so far, she's grade 3 out of 3, or poorly differentiated. And that was based on the presence of undifferentiated gland and tubule formation, high nuclear pleomorphism, and a high mitotic rate from her pathology. So continuing on with her hospital course, her internal medicine team tries to get her oxygen requirements down. They treat her with an empiric antibiotic course for community-acquired pneumonia, but really unsurprisingly, she doesn't have significant improvement in her oxygen requirements. She undergoes these biopsies, which I just discussed. And then she actually gets discharged on November 19th with supplemental oxygen and just medical oncology follow-up in clinic. She, after being discharged on the 19th, she is able to follow up in clinic 6 days later on the 25th. And I think kind of unsurprisingly, she's not really doing much better because we hadn't really done much at this point to address her underlying systemic disease. So she's still significantly tachycardic to 133. She's still on 4 liters of oxygen and appears kind of in distress. The pathology that I discussed previously was actually still pending at the time of this visit. So the clinic team obtained a Guardant 360 cell-free DNA assay to assess for the presence of any underlying somatic mutations, which could potentially guide treatment. And then, given the extent of her pulmonary involvement, she's deemed to be in visceral crisis and essentially recommended for palliative cytotoxic chemotherapy as soon as possible, kind of independent of the results of the pathology. So referral is placed to IR for a Metaport placement, but they're actually not able to get her on the schedule until like 9 or 10 days later on December 4th. And so I can advance here. So this, I think, and kind of reviewing this case, there's almost a M&M component to this, I think, because I think in retrospect, when she was, definitely seen in clinic here, she was in visceral crisis. And I think perhaps the recommendation should have been that she be readmitted from that point to begin some form of empiric systemic chemotherapy, even though we didn't have the path back, because she ended up calling the on-call fellow 5 days later. That actually happened to be me on the 30th, around like 9 or 10 p.m. And they called me, and the patient's husband said that she had been seen in clinic, but really wasn't doing that well. She was having increasing dyspnea. They had gotten a pulse ox from CVS, and her oxygen requirements were going up. So I advised that they go to their local ED because, again, this patient lives in the Savannah area. So I think they went to a Hilton Head area hospital, unsurprisingly got admitted there. And then subsequently get admitted to the ICU at that hospital. They had to put her on 15 liters via high flow. She was escalated to BiPAP, and then ultimately intubated. After she was intubated, she was then transferred back to us on December 1st. So then I'll kind of summarize her course from her second hospitalization here at MUSC. So on presentation here, the ICU team gets repeat imaging, and I've included some screen grabs from her CTPE from December 1st. So as you can see, her metastatic disease burden within the lungs has kind of rapidly progressed since just 2 weeks ago. She has kind of worsening bilateral consolidations and ground glass, and it's really involving kind of all of the lung lobes on both sides. The radiologist also commented that she now has increased size and number of lesions within the axial and appendicular skeleton as well. And then this is just some imaging from her abdomen as well, which I guess unsurprisingly shows worsening disease within the liver, worsening disease within the spleen in that middle image there. And then I included one of the thoracic lytic lesions that you can see on the rightmost image there. So really just kind of aggressive, rapidly progressing disease in a young, otherwise healthy lady. And she's progressed really rapidly over the course of just 2 weeks. So the ICU team, to further characterize her hypoxia, she undergoes a bronchoscopy on December 1st. Per their procedure note, her airways appeared diffusely erythematous and edematous, basically throughout all major bronchial segments. They performed a BAL from the right middle subsegment, and I put an image of what they found at the top right there. So she had kind of uniformly bloody appearing lavage and all aliquots. The Pulm team sent various cultures and cytology from their BAL samples, and the cytology ultimately showed atypical cells concerning for malignancy, which is not surprising based off the CT findings. So again, they started her on broad spectrum antibiotics. We are consulted again, and then upon initial evaluation, given that the patient is intubated, I think was on some low dose pressors at this time as well, she was initially deemed to be too unstable for any form of systemic therapy, including chemotherapy. But by this time, we had the pathology back showing that she had, HER2 positive breast cancer. So we discussed the possibility of starting systemic therapy with this regimen, including trastuzumab, pertuzumab, and docetaxel, if she was able to be extubated. So I was just going to do a brief aside now to talk about the Cleopatra study, which is the justification for why we recommended that regimen to start. So this is basically the regimen that we use first line for metastatic HER2 positive disease. And it includes 2 different HER2 agents, pertuzumab and trastuzumab, plus a form of systemic chemotherapy with docetaxel. So this study was published in 2015 in the New England Journal. It enrolled a large number of patients, over 800. They were split up about 50-50. So the treatment group received both of the HER2 agents, the pertuzumab and trastuzumab plus docetaxel. And then the control group received just trastuzumab plus docetaxel with pertuzumab omitted. And I put basically summaries of the significant findings. So the treatment group essentially had both improved median overall survival and improved median progression-free survival. And I won't read these out, but here are the exact figures, but they are statistically significant, and the confidence intervals are non-overlapping. And I put the Kaplan-Meier curves here on the right, which show pretty clear separation of the curves throughout the duration of follow-up. And these patients were followed for a pretty long time as well. Looks like, up to about 70 months. And then I was going to talk a little bit just about adverse events in this study. So really, there were similar rates of adverse events between the two groups, and most events, if they did occur, were mild, graded as 1 or 2, and they primarily occurred with docetaxel administration. There were somewhat higher rates of diarrhea, skin rash, pruritus, and muscle spasm in the treatment group. Interestingly, there were actually slightly lower rates of LV dysfunction in the treatment group, despite the use of 2 different HER2 agents, which I found somewhat interesting. And then I was just going to talk a little bit, because I'm talking about these agents, trastuzumab and pertuzumab. I wanted to just kind of review the mechanisms of these different agents. So they both act on the HER2 signaling pathway. So HER2, as we all know, stands for human epidermal growth factor receptor 2. And it can be overexpressed in a certain subset of breast cancers. When it's overexpressed on the membrane of these tumor cells, it then has this propensity to dimerize with other receptors and proteins on the cell surface. So it can dimerize with itself and create a HER2 dimer. It can also dimerize with other kind of members of the HER family, including HER3 and HER4. It can also dimerize with EGFR. And then when this occurs, these proteins get phosphorylated on their intracellular side. And this in turn activates various downstream signaling cascades that result in oncogenesis and uncontrolled cell growth. So both of these agents are basically working to counteract this effect. And there's really only a mild difference between these two agents. So both trastuzumab and pertuzumab act on the HER2 molecule, but they just act on a different subdomain of that protein. So trastuzumab acts on subdomain 4, while pertuzumab acts on subdomain 2, which is actually considered the dimerization domain. So it's thought that pertuzumab has a little bit, greater ability to prevent that dimerization and kind of thereby inhibits downstream signaling. So I just wanted to review that. Going back to the hospital course for this patient, so she's really sick in the ICU. Here's an image of her lungs on December 7th, just looks horrible. We're trying various other, kind of supportive strategies, including antibiotics, steroids, inhalers, diuresis. But despite all this, she has, worsening oxygenation and ventilation. I put her vent settings and blood gases from December 1st and December 6th. So as you can see, when she gets admitted here on the 1st, she's on pretty minimal vent support, just with pressure support ventilation. But by December 6th, she's on full assist with pressure control ventilation with a high FiO2 of 70%, PEEP of 8. And despite those aggressive ventilator settings, she's still pretty significantly hypercarbic to 71. So not good. So by this time, I think I was on the service at this time, and we kind of had the realization that this lady was probably going to die if we didn't do something. So despite the fact that she was still really critically ill, we had a kind of goals of care discussion with the family and decided that we were going to give it a shot and give some systemic therapy with the goal of kind of reducing her cancer burden within her lungs and hopefully liberate her from the ventilator. So we decided on this regimen of dose-reduced paclitaxel and trastuzumab. So if you remember from the Cleopatra study, first line is actually docetaxel. I think we chose paclitaxel because in general, it's deemed to be a little bit more gentle compared to docetaxel. And we did implement it at somewhat of a dose reduction compared to what was used in the Cleopatra study. And then the trastuzumab as well, the loading dose was a little bit of a lower dose at 4 mg per kg. I think within the Cleopatra study, they used a loading dose of 8 mg per kg. So she gets her cycle 1, day 1 on December 6th. By the 12th, the ICU team feels that, she's still not doing great, but they actually feel that her ventilator settings are improving somewhat, and I put her settings on the 12 listed there. So she's still on, volume control ventilation, but the ICU team does feel that she's maybe doing a little bit better. A week later, by the 13th, we decided to keep going with it. So she gets her cycle 1, day 8 of the same regimen on that day. She's, again, kind of making small continuous improvement. They're trialing some SBTs, but really unable to get her off the ventilator. So she ends up receiving a tracheostomy on the 18th. But then just a couple days later, she's actually back on just kind of minimal vent settings with pressure support ventilation with an FiO2 of 40% and a PEEP of 8. So it really seems that she's actually kind of responding to this regimen, despite, being really critically ill, which is fortunate. On the 21st, we give her cycle 1, day 15 of the same regimen. The trastuzumab, I think, actually gets a little bit dose reduced to 2 mg/kg at this time. Around Christmas time, I was still on service at this time, and I remember she actually started making really significant improvements. She had to receive a PEG for nutritional support, but she was actually alert, off sedation, and was actually walking around the halls of the ICU on a ventilator, like following simple commands, and really looking much better than she did just a couple weeks prior, which I thought was pretty amazing. On the 29th, so we transition her to docetaxel. So that's the chemotherapy that's used in the Cleopatra regimen. Continue the trastuzumab, and this was kind of with the goal of getting her to that Cleopatra regimen when she follows up in clinic after getting out of the hospital, because it looked like, thankfully, she was going to pull through. And here's an image of her lungs on the 21st, which still show pretty significant disease involvement, but looked much better compared to previous. And then she gets discharged just before the new year on December 31st. She goes to LTAC and has medical oncology follow-up arranged. So she spends, most of January within the LTAC kind of rehabbing, wasn't getting any systemic therapy during that stay, presents to clinic with us on January 27th of this year, gets her cycle 3, day 1 of docetaxel trastuzumab, and then we add on the pertuzumab since she's doing significantly better in ambulatory and able to follow up in clinic. She continues kind of that regimen every 3 weeks. She ends up getting 8 cycles through May. And then with subsequent cycles, the docetaxel is subsequently held. She was doing well, but I think that's just per the study protocol and what they recommended for patients to not kind of go beyond the 8 cycles of systemic therapy. So for cycles 9 through 12, she just got the HER2 agents. And I put some additional imaging at the bottom, which shows that her lungs look a lot better. I think I still see kind of some ground glass, but looking significantly better. However, her abdomen at this time, by August, did show some evidence of kind of worsening visceral disease involvement within the liver. So we actually, or the outpatient team actually made the decision to go to the next line of therapy based off that result. And she does have this large, pretty dominant hepatic lesion within segment 2, I believe, of the liver that appeared to be getting worse. So her clinic team then changes her to this second line agent, trastuzumab deruxtecan, brand name in HER2, which I'll talk a little bit about the mechanism of in the randomized trials that support its use on subsequent slides. But this is really our go-to kind of second line agent for progression of disease. And she's actually still receiving this regimen every 3 weeks. She's gotten 6 cycles to date, with her last being just a couple weeks ago on December 8th. And I've actually had the opportunity to follow up with this patient in continuity clinic. And it's pretty cool because she remembers me during her inpatient hospitalization, despite the fact that she was so critically ill and not really able to verbalize or communicate. But she's since told me that she remembers me, and it's a pretty cool experience. And yeah, so I know we're kind of running out of time. If you guys have other places to be and need to hop off, I won't be offended, but I was just going to talk a little bit about the Destiny Breast-03 trial, which is what supports the use of trastuzumab deruxtecan, also known as HER2, for second line HER2 positive disease. So this was basically a head-to-head trial, which basically compared 2 different antibody drug conjugates. So the Enhertu, which is trastuzumab conjugated to deruxtecan, which I believe is a topoisomerase inhibitor, and it compared it to Kadcyla, or trastuzumab emtansine, in which case trastuzumab is conjugated to emtansine, which is a microtubule inhibitor. And basically the takeaway is that the Enhertu group seemed to have better outcomes with both improved 12-month overall survival and improved median progression-free survival. And here are the figures with their associated confidence intervals, which are non-overlapping. And I put the Kaplan-Meier curves here on the right, which again show pretty significant separation in the curves throughout the duration of follow-up. And then just briefly, these regimens are both pretty well tolerated. There were somewhat higher rates of treatment-related adverse effects with the Enhertu group, and this included higher rates of severe events, so grade 3 or 4. Most common side effects were cytopenias, nausea, vomiting, fatigue, and transaminitis. Also with these agents, you have to think about interstitial lung disease, which is a pretty unique side effect for these. The majority of cases in this study were mild, thankfully. This is a slide that just kind of summarizes the mechanism of Enhertu. So it's an antibody drug conjugate, similar to EV, which Rezwana talked about during her presentation. So it's just a chemotherapy that is covalently linked to a monoclonal antibody. The complex gets endocytosed and then released into the cell. Another kind of interesting point is that it's kind of hypothesized that Enhertu works a little bit better than Kadcyla because the chemotherapy component of Enhertu, that deruxtecan, can actually diffuse into nearby kind of HER2 low cells because it's membrane permeable. So it can kill tumor cells that kind of have mixed expression of HER2. And that's kind of termed the bystander effect. And it's kind of the hypothesis as to why this agent may work a little bit better. Kadcyla is conjugated to a chemotherapy agent that is not membrane permeable. So it's thought to not really have that bystander effect. That was the majority of what I wanted to talk about. I just had a couple more slides. Like I mentioned, she did have this Guardant 360 cell-free DNA assay sent during her initial clinic visit to test for the presence of somatic mutations within the cancer. And it actually did result positive for this BRCA1 mutation. And again, this is a somatic mutation, so not a germline mutation. From what I could tell, the patient actually never had germline mutation testing sent, so it might be something to consider down the line if she has progression on her current regimen. But if you look at the bottom, they said that this somatic mutation was detected at an allele fraction that was so high that it was indeed suspicious for a germline origin, which I think would be unsurprising, kind of given her family history. And then, whenever you have BRCA positive disease, you think about the use of PARP inhibitors, those poly-ADP ribose polymerase inhibitors, which essentially act on enzymes involved in DNA transcription and repair to cause their anti-tumor effect. But per NCCN, the PARP inhibitors are generally only recommended for HER2 negative disease. So this is a table from NCCN basically describing all lines of therapy for metastatic HER2 positive cancer. And as you can see, the PARP inhibitors aren't really listed within this table as an option, but they do kind of put this footnote at the bottom, which I surrounded with this red rectangle. NCCN does recommend assessing for these BRCA mutations in all patients, regardless of their HER2 expression. And they say that while PARP inhibitors like olaparib are FDA indicated in HER2 negative disease, you can consider using them if you're kind of out of options, although there's kind of lower evidence for their use. So I don't know if anybody here has experience using PARP inhibitors. I don't know if Dr. Siva maybe. I've just wondered if this could be like an option down the line for this patient if she ends up having progression, or if we would be more likely to kind of go to these other third and fourth line therapies recommended by NCCN.
Yeah, no, that's a good point. The reason why NCCN is recommending it as a possible 2A, category 2A, is because none of the PARP inhibitor studies included the HER2 positive population. They were only focusing on the triple negative and hormone positive patients. But that being said, if this patient has a germline BRCA mutation, and once she is exhausting all the traditional HER2 positive options, then I would certainly consider to give her. And whenever you see variant of allele frequency at that high level, which was 83%, definitely, there's a very high likelihood that this is a germline mutation over somatic. So this patient definitely should get a germline testing, because it has implication not only for the patient, but also for her whole family to get tested and also have better screening. Oophorectomy becomes an important thing if she has BRCA1. So there's a lot goes once you diagnose them with this germline mutation. So if I would say maybe going back to the team and seeing what they did and suggesting that would be a good thing. And just to give an update, after ASCO, at ASCO, the Destiny Breast-09 trial was presented that was comparing the Cleopatra regimen to TDXD, and now TDXD is the first-line standard. TDXD is superior to the Cleopatra regimen. So after 10 years, now we have a change in our first-line treatment. And just 2 days ago, FDA approved TDXD as first-line. So all this, is going to change. NCCN is going to probably change the first-line guideline recommendation very soon. So it's good that we have multiple options for our patients, and all of these very active agents are sort of moving earlier and earlier. And then at ESMO in September, there were 2 studies looking at trastuzumab deruxtecan in the neoadjuvant and in the post-neoadjuvant residual disease setting. So it won't be surprising to see maybe next year we would even use the same drug in earlier stage patients. So again, the field is moving forward and we are able to cure more and more patients, but those who present with de novo metastatic disease, especially in the HER2 positive setting, we have such great treatment options and they're living for many, many years. And even we are thinking, can we even cure a subset of those HER2 positive metastatic patients with such advanced treatment options?
Thanks, James. Several things in this case. And maybe, Abhi, you know the answer to this. When you think about the Cleopatra study, what was the objective response rate in that? Because that, for somebody with visceral disease, that's what I want to know. Am I going to actually shrink this tumor? I find that outcome measure to be much more important than the median overall survival, the median progression-free survival, if I'm worried about actually trying to have a response to, to try to get this patient off a ventilator. I was just curious, because I didn't see that on what James showed here. That's one thing I mentioned. And I know this may be a question for Dr. Becker, is if you're talking about using antibody drug conjugates in the hospital for somebody like this, man, that's expensive. So I don't know if anybody's thoughts about that, because I said that those, they're at least in the hospital, they're always trying to give the cheapest drugs possible. And, an antibody drug conjugate would be a significant increase in potentially how much those drugs cost to administer in the hospital and reimbursement, et cetera, et cetera. But anyway, just two thoughts off the top of my head.
Yeah.
Can I just say something? I was the attending who treated this patient inpatient.
Mm-hmm.
So basically, this patient is alive because we treated her inpatient and gave her a chance. But it was not easy. So number one, to clarify why I chose weekly dose, because she was a very sick patient. And it was not only lungs. Lungs were major, but throughout that, she had abdominal distension, bowel obstructions. She had altered mentation, seizure-like activities. She was found with brain metastases. So that was happening few days of her admission. So there was no chance for us to give her any chemo even. But the timeline she got treatment, it was miraculous anyways. So basically, ICU team wanted to have at least a week of antibiotics or treatment just to make sure this is not pneumonia and they can do something. And eventually they told me she's dying, so we okay. Just if family is okay. We have no objections to treat her. Why weekly? Because paclitaxel, Taxol comes weekly dose. So we can give her small doses of chemotherapy rather than 3 weeks dose, high dose docetaxel, which would be challenging when you have very concerning situation. Patient may die, and they did understand family and entire team that could happen. So that was the reason weekly paclitaxel. It's more gentle, and docetaxel also you can have like fluid overload and retentions. So we are just trying very gentle. Initially, I was thinking just Taxol because, again, challenging getting HER2 drugs in patient, but we were able. So I got studies when these regimens have been tried and had success rates. So we provided studies to those people in leadership who needed to approve that. So they approved, and we had to prior authorize this week by week. So I was getting like messages from pharmacies, hey, they're thinking we are killing this patient. What we can do? Well, we have to keep going because I can see her lungs are clearing. So, and everybody was thinking, no, it's going to kill the patient, but she would have died anyway. So
No,
basically, there's many challenges when given these important drugs in patients. So
no, that's a fantastic save, Dolly, and again, tremendous effort from you and the team to make sure that this happened. As I said, I was just curious for a couple of questions.
Yeah, just to answer your question, Dr. Lockhart, the responsive rates were like 78% from Destiny Breast-09 when they compared to Cleopatra.
Okay.
Cleopatra was about 78%, whereas DB-09 was 85%. So again, if there is a cost involvement with the first line usage of these drugs being prohibitively high, it's okay to go with the taxane and Herceptin Perjeta to get started in the hospital. If we cannot get ADC, at least something is better than nothing. But eventually, when they get discharged, we will be switching them to the most updated treatment regimen for them.
No, I agreed.
Definitely
I'm just curious
And,
as to, because they always tell us which drugs they want, which drugs
we
they'll
treated this
approve
patient
or not.
was because it's effective. We have effective treatments for that. It's highly effective treatment. So that's why it was any other type of breast cancer, most likely she would not be alive. But she's only alive because she had HER2 positive disease, which is highly treatable, even in metastatic setting. But she was very challenging because she came intubated and just very critical situation.
It's interesting, how HER2 has sort of the perception of HER2 has changed. I mean, when I was, a trainee, HER2 was terrible. It was, you didn't have any treatment options for it. It was the prognosis was worse than anything. And it was just, just because of all the different options that you have now, HER2 is considered differently. And people still consider it aggressive, but it was it was the worst kind of breast cancer to have. Back then, because it was more likely to have brain mets. It was very, very aggressive, and just because of all the different options that we have available, it has really changed the way we think about this drug. I mean, again, I'm way older than everybody else on here, but at ASCO, when Herceptin was first presented, people were just crying. It was just, all these people came out of the presentation just bawling because the trastuzumab had been so it had been so beneficial in the clinical trial. So it's just a way that this is thought about differently nowadays. It's interesting.
Dr. Lockhart, I would just like to echo some of what you just said. It's my opinion, and I don't treat patients with breast cancer, but I think in the field of oncology, the magnitude of benefit that HER2-directed therapies have made. It's really, and this case is exceptionally illustrative, but I think not even immunotherapy or any other treatment paradigm, perhaps imatinib and CML, maybe an analogy, but I don't think anything else comes close to the magnitude and impact that this class of agents has had in the treatment of this disease. And I have said this before and say it now, that I think Dennis Slayman should be nominated for a Nobel Prize for this effort. I think I don't say this lightly. I mean, I don't go out nominating people for Nobel Prize, but I think if there's one person who I feel so strongly with if we think about who gets the Nobel Prize, it's people who are making global impact on issues, and I think this is one such issue. So I so strongly echo the sentiments that the group has.
Yeah, it's as I said, it absolutely changed the way that we think about HER2 positive cancer. As I said, I'll never forget it. That there were people cheering and crying during the session when trastuzumab was first presented at ASCO. I don't know what year that was, but anyway. Thanks, James. Does anybody else have anything to add? Because we're over time.
We are over time. But yeah, no, thank you, everyone.